Aravind with us, who is a palliative care physician. He did his MBBS from Trivandrum Medical College, and his previous working experience is in the surgery ward and emergency department, and also in the general medicine. So the last 6 months, he has working here as a palliative care physician. Aravind, welcome and over.
Thank you. It's a great, honor to be told by, actually, because she is also my teacher. She told me what is the basics of palliative medicine and the basic pain. So that was a brief introduction of me, and then I think we'll go into the topic proper. Let me just share my screen here. I think everybody can see, right? Can I get the response, please?
Yes, sir. Yes, doctor.
Yeah, thank you. So today is the basic thing that we are going to talk, which is not, is it important or not to talk about pain? That's the one thing that we usually think a lot. Because pain itself is one of a modality which actually tells you why it happens or how it happens, but it also gives you a very improving section of understanding one's own. See, understanding of pain is very different to different people. What might cause me pain is not something which may cause you a pain. So understanding of pain is very important when you come into palliative care, because it is all about how people take it, or how people believe in it, or how people understand it. So we'll just go with a brief thing, and I want a lot of interaction from you people, because the main important thing is, having interaction is, I'm not just here as a person who are going to teach you what is pain, because like everybody in this group, that everybody sitting in this group might have undergone some or the other kind of pain. So I'm not here to teach pain, but we are here to understand pain. The basic understanding of what the pain is and how to make other people understand is the basic thing that we are going to go through with. So we'll go with the first slide, which is what is. Can anybody say just like write in like a few, 3 or 2 words? What do you understand about pain? What is the basic thing what clicks in your mind when you say pain? Can you just type in the response, please? Or can anybody say? The meeting is very open. Anybody can just come in and talk whatever you want at any point of time, please. Okay, Maria has written that hurts. Okay, we do say that. Yeah, it literally hurt me. And then anyone else? It would have been so happy if I could see a lot of more faces. Okay, everybody has kept their videos and everything paused. Disturbance of normal life. Yes, Lisa, you're right. Reena, I'm sorry. So actually, the one thing which I wanted to tell is, so many people will have so many definitions of pain. Yes, physiological and can I just see the chat, please? Yeah, Vinisha has written that it is psychological and physiological response to a nocturnal stimulus. Okay, that is a pretty one thing. Unpleasant signal that something is yes, noxious. So yes, the sole reason for me asking this question is actually dependent upon that what is actually your definition, or what is the one thing which you can define pain. So technically we have a definition. WHO has given a definition, and it states as an unpleasant sensory and an emotional experience which is actually associated with actual or potential tissue damage, or it is described in a terms of such damage. It is just a line which we usually read, but we don't know the depth of what is being written in such a line. It is just a single sentence, it's just one sentence which the WHO has given, but it is unpleasant. You break in the words one by one and you understand that yes, it is unpleasant. It is sensory or an emotional experience. So I hear that my father dies, or I hear my mother dies. It is a pain which is only, that kind of a pain will only affect you, that person who has really had that kind of an emotional attachment to that person. And when you are asked, are you in pain? Even though physically I'm fit, physically I don't have any other issues, the literal thing of psychological pain or the psychosocial pain, that really matters. That really matters in a patient who really has gone through that kind of an emotional stress. So in palliative, We have seen a lot of people having so many of agony, so many of emotional debilitations, so many of other concerns, which actually cause a lot of problems to others. So emotional and sensory is one of the thing which is thing, and then associated with an actual or a potential tissue damage. So we will be talking further with the tissue damage part, but this is one of the definition that is being internationally accepted. Wherever you go and you just define pain, this is one sentence that you can tell to anybody in any sense. Okay. So these are some personal things that I need to tell about pain. That is, as I told you, pain is a very personal experience. It depends upon person to person. It doesn't mean that what makes me a painful stimulation, that the same stimulation can I give to Shiva's sister will not give the same kind of an effect or the same kind of a stimulation. So the stimulation depends upon a personal intake of what pain is. It completely depends on here. Your brain is the one thing which actually causes you to tell what kind of a pain you are going through, whether it is physical or anything. We'll come to it in the later parts. And difference between a pain and a nociception needs to be clear. Can anybody give me a one-word answer of what nociception is? Nociceptive pain. We have talked about nociceptive. We will come into it. But still, nociceptive pain. Any single answers for that? What is nociception? Nociceptive.
Detection of pain stimuli, pain giving stimuli,
Very
stimulus.
good. Very good. That is the one thing. Because we have so many free nerve endings in like every part of our organ, which is having a noxious stimuli, which can catch in these kinds of stimuli which can affect our brain. And still, mind you, we don't have a particular cortex in our brain which actually identify what pain is. Pain is actually a very conglomerate, position where it comes in different stimuli and modalities, which actually hits your brain to make you understand that it is not a right response. We feel happy, we feel sad, we feel like all the other emotions, but pain is a one emotion which doesn't fit into the category of an emotion, because pain is something which you just feel, you just understand that it is unpleasant, you don't want to be there. So that is one thing which is actually, so the actual difference between the pain and nociception, that is whether the patient is really having a thing which is a triggering factor which is actually causing him pain, or whether just is the other thing, which I told pretty earlier, whether that like somebody very close to me just passed away and is it that kind of a pain. It really, really matters when you go into palliative care, because once you understand what kind of pain he goes through, that itself is being, I see that somebody has sent, will you please repeat the audio being stuck for a while? Hema Padma. So where do you want me to, restart with?
After this nociception, it's been stuck for a while and I wasn't able to click
Yeah. Is it because of the
continue.
mask? Should I remove the mask?
Yeah, it's not like the audio was completely
The audio was cut. Okay, fine. That's
Yeah.
okay. No, what I was telling Hema was the difference between the pain and the nociception is what we need to understand how the person perceives it. Nociceptive pain has a pathology behind it, because there might be a noxious stimuli which is actually causing the person to feel that kind of a pain. But when it's not a nociceptive thing, it is about just a pain, which can happen in any other way, a psychosocial pain, a psychological pain, or a very disturbing news that can actually cause you pain. Anything, pain is either physical, or it can be an emotional thing, or it can be a psychosocial thing. So we have to understand whether this is a pure nociceptive pain or whether it is something caused by an actual event. Now, the next thing is patient's expression of pain is to be respected. Somebody who comes to you crying and then saying that he's in pain, you will literally go and you will understand that, okay, this person is in really pain because he's crying. His emotions are the one thing which tells you that this patient is literally having pain. Is this the right way? How many of you think that it is in the right way? That we should see the emotions, we should see all the suffering that he's going through, and then we get to the diagnosis that, okay, he's literally in pain. Somebody who's coming to you and saying that, oh, doctor, I'm having so much of pain here, I just can't move this limb. That's it. He just sits pretty fine. Do you believe him or not? Will you believe him? Because as a palliative care physician, I see a lot of people coming to you expressionless, saying that they have so much of pain. They are undergoing so much of pain. Should I believe them or not? This is a $1 million question that you ask like any palliative care person who is working. Is the audio on? Can anybody hear me?
Yes.
Okay, check. Okay, so there's one thing which we need to understand whether the patient's expression means a lot or not. Can anybody just say whether that has to be taken in or not? Somebody comes to you very, fine, and then yes. From Reena. Reena says that yes, we have to believe. There is some noise disturbance. Let me take a while, please. Yeah, there might be a small, clapping sound behind. Just don't care. Okay. Okay. So what I was saying that a lot of people have said that the patient's expression doesn't mean, but it has to be respected in every sense, like in all the sense that it has to be done, it has to be done. So the next would be usually said to be a symptom, but can be a problem too, right? Because over a period of time, when we see that some symptoms that the patient might say, you have an abdominal pain just because you have a renal colic. A patient is coming to you with a kidney stone. Patient is actually coming to you and he's saying that I have a stone. Here there's a diagnosed case of probably a renal colic. The patient might be coming to you and saying that, oh, doctor, from yesterday night, I just had a pain. It's just a symptom. The pain, what he says, is just a symptom. But think because of that symptom of a pain, literally the patient couldn't sleep the whole night because he was in pain. So the symptom of a pain really made his life worse. He couldn't sleep one day. He couldn't sleep a day. So that becomes a problem. So this is very important. Even though these things are very infutile, all these things are very important in understanding what the person is going through and what role the pain has in their body. And also, not only patient's expressions, the verbal expression is not only the mode of expression. The patient should not just come and say that I am a lot in pain. No. Somebody comes and sits in front of you and then he just grins. He just shows that he has pain. He's not literally saying that I'm in a lot of pain, I'm going through a lot. He just have to come and sit silently in front of you and you need to understand that what is. So this is a multi-dimensional thing. It is not that it is as a dictum that the patient will come, patient will show something, patient will do something, and then you got to diagnose that the patient is having in pain. So this is one thing that you need to understand over a period of time, because this is the one thing which we are going through together. Okay. So please see this person. I asked him to go down and he is just simply walking down and then he falls. Okay. He just fell down and he's showing something like this. This person is literally, and he just fell down and we know that, okay, he fell down. And because we know the history that this has happened, we know that because he just fell down a big stairs, right? And now another person who just comes in and see that the patient is doing something like this. Most of us will think that, yes, he's in pain. Like he might be, in pain because he is holding his knees and then he is crying. So much of emotional, so much of physical, so much of other things are being put in place so that the drill which comes through your mind should not have an ambiguity saying that whether this patient is in pain or not. It's not decided by you. It's not decided by us, whomever we may be. We might be a palliative care physician, you might be a palliative care nurses, you might be anybody, big shot in the field, but patient's pain is not detected or not controlled by you. So who can tell? Like who can tell his pain? Can anybody tell about that? Who can tell his pain? I only see a few people answering. Always be more, Yes, like he himself can tell it, right? Nobody else can tell his pain. So what do you understand from this statement? I just made this whole conglomerate thing because if I wanted to make a statement very precise. And what do you think that I wanted to say in this thing? What is the one thing that I need to tell? And then we'll go into the topic proper. Yes, himself. Only he can. Only he can tell his pain. So what is the one thing I want to tell in this? Who should be believed? Who should be believed? Is it our instincts? Or is it our science? Or is it our palliative medicine, so-called hi-fi short things? Or is it the patient? So, yes, like everybody said, yes. Just through interaction, we understand that. So the one thing you need to understand, the takeaway message of this whole thing is you need to believe the patient. You need to believe what the patient says to you. If he says that he's in pain, please, please, please understand that he is in pain. Nobody will come and just, blabber. There are few people, there might be few people. I'm not generalizing or I'm not throwing a blanket statement that everybody will be coming to you with the truth. Even I have seen personal cases where people might just say that I'm in pain. But in most of the cases, I would say 99.99%, you might have to believe what the patient says. Okay. Yes, Reena, you're pretty right. We should also understand his pain, because the one thing which actually comes in understanding, you might be just going through a lot. The person might be going through a lot. And when he tries to talk to you about something, understanding is something that you need to have. We'll come to it. We'll come to it on later part. So till now we were just talking about, one second. What is this? Video. Yeah, I'm so sorry about the disturbance. We actually have some construction or something going on here. Audio is good? Okay. So this is our basic, pain pathway. This is the most hi-fi thing that we learn, as doctors and nurses. We actually learn about the pathways. So many of pathways that we have actually learned, right? Which takes our fine touch, which takes the crude touch, which takes temperatures, heat or cold or whatever, which takes in like pain. Can anybody tell what fibers take in pain? What important fibers are the ones which usually take pain? The fibers are usually used to transport the things, right? So if I prick something here, this has to go right down to my brain saying that, okay, something is here and I need to take my hand away. So what is that? Well, which nerve? Can you see me which nerve, Maria? Yes, it is the nervous system, but there are two fibers which are actually very, going in close with it. Yeah, it is the nervous system. Yes, the afferent. Yeah, Hema, right. It is afferent. I'm talking about name the fibers. Okay, could you please name the fibers? We have so many fibers, right? We have alpha fibers, we have beta fibers, we have say type 1 fibers, type 2 fibers, type C fibers, A, B, C. We have learned a lot of types of fibers, right? Which take in slow pain, fast pain. Well, I'm just going to say it is just like A delta and C fibers are the ones which actually take in pain, where the A delta fibers are the one which take in fast pain, and C fibers which take in the slow pain. And this straight for the record. It's not a big thing. It's not a big high shot thing. But still, when some injury is there on your hand, such as this photo which I've been showing here, which is having a pin prick, there are a lot of sensory stimulations which is going on. So this person will be having a lot of prostaglandins. The PG which is written here as prostaglandins, which are provoked by the inflamed damage of cells, and then these are taken up by the nerve roots, as you have said very rightly, that is the afferent nerves. These sensory nerve fibers will be taking it, and these are the first order neurons, as we have studied earlier. This is the first order neurons that taken up, and this has been traveling up your brain, and then this thing will give you a sensation of pain. That sensation of pain is different for different people. This is the first thing that I said in my first slide, that the perceiving of the pain is different for different people. It might not be the same for me, which is not same for her. So this is one thing that you need to understand. This perception is different for different people. Some people that you have taken GRBS, right? Everybody literally have taken the GRBS, right? I can see most of you people just nod your head at least. A lot of you people have taken GRBS, and I'm pretty sure that when you put in, you have seen a multitude of responses. Some people like, oh my god, it's so painful. Some might be like sitting like, what, only this? So we have seen multitude of responses from different people having the same stimulation. So that kind of a same stimulation happening is how your brain interprets. It's how their brain interprets. the same stimulation. So this is the same thing which I have been telling you. So this is one thing you need to understand, that same stimulus for different people, different outcomes can come in. So don't say that, oh, that patient just had a small stimulation and he's showing such a big pain. We are not to judge here. We are not here to judge and make understand that the patient is going through. It is the patient himself who can say what he's going through, right? So this is where we need to put down all the things which we have in our mind and be non-judgmental about patient's pain. Pain is something which cannot be judged by a second person. If I have pain, the only one person in this entire universe who can say my pain, it's me. That you can relate it for yourself, right? So why do we need to tell all these details? Why it's just a topic of pain. It's just a one word having a one sentence line, explanation. Why talk so much? It's because this is the same reason why I have written here, that is, pain is a multidimensional and a complex phenomenon that requires comprehensive, ongoing assessment and effective management. Am I audible now?
Yes, sir.
Okay, thank you. Thank you for the feedback. Thank you. So what I was just saying is, we have a multidimensional and a very, a complex phenomenon which actually makes you understand that understanding pain is different for different people. So that, gives us a very, very important question in our life, that why is pain is good or bad? Is the pain good or bad? As palliative care nurses or as general nurses, you need to understand one question in your mind: is the patient is telling about a pain? Is that a good sign or a bad sign? Is it a good thing or a bad thing? What do you all say? What do you have to tell? Just type in good or bad. I just want to hear it. That's it. It is a good. Yeah, Priyanka has said it's a good thing. Yeah, Rahul has said it's a good thing. Dinisha has said, anybody saying it's a bad thing? Is pain is a bad thing? It's a very, you can't go through it. Does anybody have that kind of a suggestion? I'm so happy to see so many responses. Thank you. Bad in cancer cases. Okay. Okay, Ashwati, can you talk? Can you talk just? Is it okay if you can talk, Ashwati? Ashwati, can you unmute yourself? Just hit the button and unmute yourself, and can you just explain why you said it is a bad thing? Ashwati? Okay, I think Ashwati didn't understand. Ashwati, can you hear? Okay, that's okay. We'll go ahead. See, for people who have said it's bad, actually, one thing, yes, to go through it. Yes, Ashwati, can you? Yeah, I saw your chat. Ashwati, can you please unmute your mic and just say network problem? Okay, fine. That I can understand. You can just type in what you felt till I just explain what I need to say. Okay, just type in. Okay. So there is a noxious stimuli in your body, and you know that it is noxious. You don't want it. You don't want that kind of a stimulation in your body. And this is the same thing your body is trying to tell you. Just understand that thing. You don't want pain in your mind. You don't want to go through pain in your mind. But just think that whether the body is trying to tell you that, okay, something is making you upset, or something is making you in an unpleasant situation, move away from that situation. You are in this class and you don't like me, screaming like this and talking to you like this, and you just, get so much of irritated and you have so much of pain in your mind. Irritation itself is a pain, and you just logged out. You have an option, right? Because just because you felt irritated, you felt painful, or you felt some irrational thinking, you left. That is the one thing God has given us in the body. If you feel pain, it means something is wrong there. Your body is literally trying to tell you that you are not okay. The thought is not okay. You get a small prick, you feel that it's a pain there. And that itself constitutes the reflex arc. Like most of here are, I'm not generalizing, but still I can see a lot of female faces here. Like you might have seen in the, in the kitchen itself, when you're just going and you're just lighting up something and your burner just burst up, you just pull your hand back, right? How does that happen? You have heard about the vertebral pain arc, right? It's a reflex arc which happens. You try to you just lighter your stove and the gas suddenly comes up and the flame suddenly comes up and you just retract your finger. This thing doesn't need your brain. This thing is a complete vertebral thing. It comes from the reflex arc so that you withdraw. So this withdrawal thing is in physical situations. What about things which cannot be withdrawn? Like a pain somewhere in some place or something. You can't just chop off your head and then throw away your head, right? You have to go through it. You have to go through that pain. So literally, body is trying to tell you. So in all sense, even if it is in cancer cases, your body is literally trying to say. But what Ashwati said is actually in a right sense, because when you go through that kind of a pain for a long time, we are talking about all the things which were in a short period of time. But when you go through this for a longer time, this is really going to affect you. And that is one thing which I told it in my second slide, that some things may become problematic. You might go through a lot of tensions and tortures, and this literally problem might go into a really headache that might cause you a lot of problems. So this pain is actually a good thing for you to understand, for us to understand, so that we can help. We can come in and we can help them and we can make their life more good. So we'll just talk about the pathophysiology of pain. So the mechanism by which a damaging stimulus in the body is perceived as a painful by the brain is a complex one. I told you, even the topmost scientists haven't got an explanation of why we feel this particular thing called pain as an unpleasant situation, as an unpleasant, stimuli. And pain serves a purpose to prevent tissue damage and protect the body under the certain conditions, and pain can become maladaptive and persist as chronic pain. And this is what Ashwati rightly said as, it's a problem when it comes to cancer, because this is the thing which we see in palliative care more, because people who have gone through pain a lot must have, caused their own life to be in a problematic situation. And this persists as a thing called chronic pain. So we'll be going into that also. And when pain serves no protective function, so I told you pain is actually a protective function. Till then, it was good. The pain till then was very good, because we had a lot of things to happen. And then suddenly, when it becomes pathological, that cancer pain, which Ashwati was talking about, you go through it a lot. You suffer the pain, you suffer the loss. And then after a long time, the pain itself becomes a disease. As a disease which might have caused the pain in the first situation, you might not be wondering about that one. A person who's literally having a cholangiocarcinoma of the liver, he might have presented you with a pain, just a pain. So you started treating him, and then you understand that, okay, this thing won't go away. And over a period of time, over a period of 6 months, if hopefully he lives, after 6 months, the only thing he might be saying is, let the cholangiocarcinoma stay there. Take away the pain. This is the one thing. So you understand that there is a reversal of, the complaints, the reversal of what the patient goes through. So this is one thing that you need to understand. Over a long period of time, even chronic pain can happen. You might, so many of people who might be in this chat might have lost someone very close, dear and near. Are you still out of the pain? Just think for yourself. Don't type anything. This is a personal question. Just think it. Because I have lost someone very close to me. I lost my father, and still I'm in pain. If I talk about him, when somebody comes and talks about it, I'm still in pain. So that is one thing that you need to understand, that this is something which really, really matters. It's not about a presentation. It's not about, studying it, or it's not about understanding it. It is about perceiving it, perceiving the word of pain in your thought so that you understand what the patient tells you. Because in palliative, around 90% of people who are coming to you are with pain. 90%, I will guarantee you, 90% of the people who are coming to you will be coming with pain. So understand the importance of understanding their pain. So I'll just quickly, because I don't want to make this like a complete ruthless thing. You need to study something out of it. So I'm just coming into some important scientific terms also. So we'll go with types of pain, which is acute pain, which is present at the site of injury mediated by the nociceptors. So nociceptors, we have told in the earlier sessions that nociception is something which causes pre-nerve endings, which can perceive that noxious stimuli and send it to your brain saying that, oh my God, this is something wrong, please help. So this is acute pain. And what happens? Can someone give an example of an acute pain? Everybody's sitting still, making me talk. Can somebody just tell me like one example of an acute pain? Somebody, anybody? Needle prick. Yes, that is the one thing we go. Joshna has gone through a lot, I guess, making people, go through acute pain. Okay, we have all, made people go through acute pain. Thank you, Joshna, for that. And chronic pain is something which is related to pain in conditions such as diabetes mellitus, arthritis, or tumor growths, which over the period of time, like you go through and over it, and then you can see, old grannies coming in saying that, oh my God, my knee hurts so much. That is chronic pain. They just forget about their inability to walk. They just forget that their activities of daily life is being affected. They completely forget about everything. The only one thing they will be focusing on, beta pain, bacha pain, mone pain. This is the one thing which everybody is gonna say. After a particular 60, 65 or 70s, you might be seeing a lot of grandmothers and grandmothers usually because of this arthritis. And the other thing is somatic pain, which is usually generated by the nociceptors in deeper tissues. We have somatic and viscerous, which comes under nociception. We'll come into that later. And visceral pain is something with deep viscera, like the GIT pain. I told you about the colics. I told you about the renal colics. There are gastric colics, which can have so much of pain. Cramps. Girls, you know it. You know the mittelschmerz. You know the pain which happens during the periods, right? That is itself is a visceral pain. It's a visceral pain. It's having a deep, visceral pain which can cause you so much of trouble. Okay, so that is one thing. So understanding pain, I think women can do it more, can understand more pain. So we are talking about neuropathic pain. This is again caused by the damage to the nerves, resulting in an increased firing. Increased firing is the firing of the neurons. The transmission happens there, then and there, and this all transmissions, when it reaches the brain, it can be manipulated as a pain. So we can't say whether this is a neuropathic pain is a directly causing pain or is because of this overactivity. And I'll just come into some terms that we medically what we use is one is allodynia. Allodynia is something which is pain resulting from a harmless stimulus. We don't know whether the patient is going through it or whether it is having any kind of other stimulus. If a person who is having allodynia, I think wearing this shirt itself will cause that person so much of pain. That stimulus should not cause him any pain unless and until he has so much of it. That is one thing we need to understand from the term allodynia and hyperalgesia. You wear your dress and you feel pain. That is a normal stimulus. It is a harmless stimulus. We all wear dress. But some people might come to you and say that, doctor, I have so much of pain wearing my clothes. So that is the reason why I don't wear anything upon my body. So that is allodynia, which is actually a pain resulting from a very, very, very harmless stimulus. Somebody coming and just touching you, and they say, oh my God, this is so much painful. It's very painful, they say. So this is allodynia, where the stimulus is normal. The stimulus is pretty normal there. But we come into hyperalgesia, there is a normal stimulus, but the patient exaggerates the pain. The other thing is allodynia is the pain is there. It is not like exaggerated, but the pain is there. But since it is a normal stimulus and a harmless stimulus, the patient just tells about a pain. But if he comes with, when you touch me, I had so much of pain. So there is a normal stimulus, but the patient have really, it is not equivalent. The stimulus is not equivalent to the pain that patient perceives. So stimulant versus perception, there is a huge gap in hyperalgesia and in the same side of allodynia. This is the thing that you need to understand. So this term is being confused by random people thinking that, okay, what allodynia and hyperalgesia are like the same thing. So don't make it a confusion, okay? And referred pain is obviously it's a pain felt in the area other than the site of origin. We know we have seen a lot of MI cases. I'm just talking about the very common pain that we have seen in our clinical practices, right? Patient who was coming with here, he'll be keeping his hand here with an MI, and then he will say that he had a pain here in the ulnar segment of his left hand, right? You have seen it, right? Can anybody give me an yes if they have seen it? Patient who has come with an MI. Yes, so many yeses. Okay, fine. Okay, thank you. So this is a referred pain. So people might come to you with referred pain and all. So there is a one thing called baseline pair. The pain which is having the patient is in the background. We call it a background pain usually. So baseline pain is a pain which is actually felt by the patient most of the time. Like it is completely predictable. The patients, if you go and you ask him out of 1 to 10, how much pain you have, the patient will say that, okay, I'm having this kind of pain, which is always like 5. And then in between, I'm getting a pain which goes up to like 7 or 8 or 9. So that continuous thing which he's going through is a pain which we call as a baseline pain. So that baseline pain is very, very important in cases of CA or carcinomas, as we are going to talk in the future. And then the other thing is breakthrough pain, which is we know that the pain which occurs on and off and in an unpredictable fashion. And this thing is very important because through breakthrough pain, the scale might even go up to like 10. We have a pain scale which will be coming in a few slides. So breakthrough pain is also very important, and baseline pain is also equally important. Don't think that just because the patient is having a baseline pain, he can adjust. He may tolerate. You have a pain somewhere, you have a joint pain, you can't move it, but over a period of time, you just get adjusted to it. But over a period of time, adjusting it to it is a different thing when it comes to breakthrough pain. It just comes on and off like that. So this is very important. So understand the basic terminologies here. And we have a thing called incidental pain, which is pain associated with precipitating factors like motion, a movement. When a motion comes in, sets in, and then you have. This is typically seen in arthritis. You can see that the patient comes only. He will say that, okay, I just was lying on my bed. I didn't have any pain, but just when I just stood up, I just have so much of pain. So that is an incidental pain, which happens with an incidence. Just think like that. An incidence happened that he moved and then he has pain. So that is incidental pain. And end of dose pain is something some patient come to you and say that I have pain, you give him paracetamol, and then like for 2 hours he's saying that, okay, I don't have any pain. And then just after 2 hours, after the paracetamol just kicks out, then he says that, okay, I'm having again pain, I'm feeling the pain again. So this is one thing which you will be seeing when you are in palliative care, because we use morphine as a painkiller here, and you will be understanding that the action of morphine only starts for like 4 hours. It stands only for 4 hours. And after 4 hours, the patient may come again with end of dose pain. The patient will be coming to you saying that I'm feeling the pain again. So what are we doing is that we make this background pain and everything down by giving a continuous, like as we do an infusion, we give it continuously, like orally, like every 4 hours. So that the serum amount of morphine remains in an upstate where the patient can't feel any of the pain, not even the background, not even the incidental, not even anything, not even the end of dose. We don't allow the end of dose pain to come to that patient per se. Any doubts till now? Anyone has any doubts till now? Feel free to ask. If you don't know type, you can talk also. Shall I move? Okay. So now we have understood pain. Till the last slide. Okay, thank you, Reena. Thank you for understanding. Okay, so we're talking about pain assessment. Till now, we were only talking about understanding pain. All the previous slides which I have been talking about is understanding pain, or how to say or how to understand what the pain is. But now we'll understand that he has pain. How do I know that how much he has? We have to weigh it, right? We go to a store and we order something, and then we need to in a scaled formation so that we understand that how much we are buying or how much we are dealing with. That is one thing we need to understand. And pain assessment is something which will help you over the time to understand how much the patient is in pain. because it is just a verbal thing. Only the patient can say it. You can't just go into his mind and then get out what pain he is going through. So pain assessment is very important, and proper assessment of the pain is essential, and it also has been reassessed regularly. And nursing team has an essential role in this, as the patient are seen regularly and at times more often by them. So you people are the persons like who are going very, very regularly to these people, and they might have a bond which is very, very higher than anybody. If me and sister go to a home, the first person those people will be waving at will be at sister, because they consider her as more important person, because she's the person who is having a constant rapport with these people. They'll be having a completely alienated feature of a doctor, but for nurses, I think it is more important of making this rapport over a period of time. And hence, this is understood appropriately and adequately, and this has to be taken into placement. So you have understood that you need to access it. So how will you describe the thing? How will you describe? And for an easy format, I have just made it up like a C, D, E, N, F, and we have a P, Q, R, S thing. And how will you understand this thing? He has a pain. Just understand that if you are having pain, it is very easy to understand and decode the whole thing. You just want to know where you have pain. You just want to know how much you have pain. You just want to know what kind of pain are you going through. You just want to know if you want to do something and this pain comes down, can you tell me what it is? And the other thing is, if you don't do something, or if you have something which will increase the pain when you do it, this is the thing that I need to know. And I need to know whether it is affecting your sleep. I need to know whether it is having any kind of a problem which is having in your life. Can't you brush with your pain? Can't you bath with your pain? Can't you put your dress up with your pain? So these are very, very, very important. And how much time you have this pain? All these questions, which I just asked you, are written over the slides that is right in front of you. And to just understand, you are not limbits, or you people are not that much of illiterate to understand what is being written, but just to make a format in your mind to understand, to ask all these things, so that you understand that what am I going to ask this person who is in pain, so that I can literally get all the things out of it. So please, the C is for cause, the D is for duration, the E is for effect on the sleep, F is for the functional, that is activities of daily life. And we have the palliative factors, which I told you, that whether you have a pain decrement when you are taking the drugs, or whether you are lying still. A patient who is having an arthritis will say that, beta, like when I sit down, I have a little comfort. I have comfort in my pain. So that is very important. That is a palliative factor for that person. So when she sits down, she has a pain relief. On the provocating side, she says that when I walk, this pain just shoots up like hell when I try to walk, for a person who is having osteoarthritic features. So palliative factors and provocative factors are very important when we are dealing with this. And the quality of pain. I'll come to later the quality, because from the quality itself, we can understand whether what kind of pain are we dealing with. Pain can happen from anywhere. Pain can happen from a nerve. Pain can happen from your stomach. Pain can happen from your intestines, from your kidneys, from wherever possible. It can be from your skin, from anybody, from anywhere. This can happen. So this is very important in understanding the quality of pain, so that we can come down to diagnosing where the pain is from. So that is very important. Radiation. Radiation will give you umpteen number of diagnoses, whether the patient is going through a pain or not, or whether what kind of pain it is. Site is very important, and also severity is also important. But since we talked about severity, how we are going to understand what severe the patient? For me, this much of pain will be like, is this only this much? For the other person, will be saying, yeah, I have this much. And the other person might be saying, I have this much. So how will you understand how much pain is he going through? That is very important in understanding wise and in every single dimension. So there we have a thing called the pain scale, the scales to assess what the patient is going through. So we might be understanding like, oh, chota bacha, like a small kid can't say what his pain is after looking at this. So we have things for that also. We have very, pediatric friendly to most adult friendly things which can have. You don't have to go through, high school or, 10th pass to get an understanding of understanding this pain. So there is one thing is a verbal pain intensity scale. You can actually ask them, like, Amma, Appa, do you feel like pain? There is no pain, or is it like mild, or it is moderate, or it is severe, or it is very severe, or you can't even think about it. It is so severe that I can't even talk about it. Is it something like this? It is called verbal pain intensity scale. I have clubbed the whole 4 scales in a single thing so that you can even take a screenshot or you can keep it with you so that whenever you are assessing, it will be very, very useful for you. So this is a verbal pain intensity scale. But what is the problem with verbal pain? Can anybody say? What is the one thing which we literally have a problem with the verbal pain intensity scale? It is verbal, na? These people might be telling you. And the way differs, people might be telling you different opinions about their pain. They can't literally express that pain, right? Yes, can I see the chats? Chats are normal. Okay. Yes.
Excuse me, sir. We cannot get exactly idea how it is pain was there in.
Yes, very good. Vijayanti, that is the one thing which is very, yes, it is not accurate. Also, so much of you. Thank you so much. There is so much of inflows. Okay, may not be accurate. Yes, it is not accurate. May not be. Yes, everybody is the same thing. Okay, so lack of accuracy is there and understanding also. When accuracy is being diminished from patient side, just think what is going into your head. When accuracy falls there, diagnosis changes here. So that is one thing which is that's a problem with the verbal, pain intensity scale. And the other one is like visual analog scale, which is actually like if you have pain, there is no pain, and you have 2 different, points that there is no pain and there is a lot of pain. Can you just show in between here where it is? That is also, as we have talked about the verbal pain intensity scale, that also doesn't help in some cases. These can be applied in anywhere, but what is being done for the most is being the most important one is the 0 to 10 number. That is a numeric pain intensity scale that we have been using for adults. So if you can see, it has been literally written that we have incorporated everything. There is a verbal pain intensity scale which we have incorporated where we can say there is no pain. Can you see the third figure, everybody? 0 to 10 numeric pain intensity scale. So it is written there is no pain, there is moderate pain, and there is a worst possible pain that the patient can go through. And then we have again put the visual analog scale in it. So we have incorporated everything. We have incorporated the verbal pain, we have incorporated the visual analog, and we have also put in some numbers also. So patient can just verbally say, okay, I have some moderate pain. So this comes around like 4 to 6 or something. So he will go directly, his eyes will directly go to that area, and then the visual analog scale will help how much pain he has. Then he can number it. So there is an accuracy. The one thing you said was accuracy, right? Everybody was so much of intensely thinking about the accuracy of what the patient says. What do you think about 0 to 10 pain intensity scale? Do you think it might be somewhat accurate? What do you say for everybody who just said lack of accuracy? Yes, accurate. Maria said it's accurate. Anybody else? Yes, Vijayanti also is yes. She's also concurring. Anybody else? Okay, we will not waste more time. Okay, so this is the one thing. So you understood the basic concept, right? We have going through 0 to 10 numerical pain scale where we use numbers and everything. And we can't use this so much complicated things, even though I have said it so complicated, it's very easy actually. And then Wong-Baker face expression pain scale is actually very important for pediatric population. We can just go and it also has the same principle that we have actually used in 0 to number scale. It also says no hurts a bit, hurts little more, even more, and hurt a lot. And there is a, one thing called verbal thing included in it. You can see photos also. So visual analog scale is being completely turned over to photos so that you can see someone smiling, someone with less smile, someone with a very less smile, and then immediately it drops like I'm sad. And then he's literally crying because of pain. So this can be put in and then understood the basic concepts of it. So this is Wong-Baker faces as one is being used in the pediatric population. And mind you, this can be used like for anybody. We are also pediatric people, right? Okay. So next thing, what is the basic thing that you need for the pain, for the major part of the pain? The first step every time is building a relationship with the person. You come to me and you ask me that, are you in pain? What is the first answer that I'm going to say? No, I'm not in pain. Mind your own business. This is the one thing. So building a rapport and building a relationship is very important when you go and talk to a patient, because every time this is one thing which makes the patient vulnerable in not opening up things to you. He might feel really vulnerable. So the one thing that you can do is you can sit and you can listen to him. If he wants to say something, sit and listen to him. Give him his pauses. If he doesn't want to talk, just sit. Just make him sure or make him or her feel, I am there for you. I'm gonna wait this whole day if it has to be with you. Make them feel that. And trust me, they're gonna start talking. They will start talking to you. And then convey that you care for them. And the one thing which, like most of us people do, is we give them promises. Okay, I will take your pain away. I will make you walk. I will make you run. So we just give out promises which are actually impossible. What happens is that when you give your impossible, promise to them, they will feel very happy. They will get too much of attached with you over a period of time. But think that over a period of time, they will understand that it was a fake promise. It was a false promise, that you just lied to them. So somebody who took you in will directly kick you out. So this is one thing you need to say. Do not promise the impossible. Please don't do that. Even if it is for the benefit of the patient, don't give them false hope. Somebody is in pain and you give them a false hope of that the pain will go with your intervention. It might not. You don't know. So please don't do that. So what is one important thing that you have to take away today? So this is the body chart that we usually do in an IP setting or even in an OP setting. Whenever we see a patient who comes to us, we have an antral and a posterolateral areas where this is not included in this thing. It is only having the anterior and only the posterior segments. And we can just mark where the pain is. If you see that the pain is occurring from here and it goes right through here, we can say the origin of pain is here and we can shade another color or something which is going up there. So in this patient, he is having an anterior part pain. It's in the anterior, aage ka portion. So what is happening is the person will be having pain in the anterior aspect of the arm, and he has another pain right in the right hypochondrial region. So we will be immediately thinking, what kind of thing will that be? So this might be because of some local pathology that is irritating the diaphragm and which is causing a shoulder tip pain with an arm involvement. So these are the things. That is the importance of understanding radiating pain and everything. So that is very important. Yes, Reena, you have to be friendly. You have to be friendly and you need to understand what you are dealing with. Very right. Okay, so we'll just rush up with things. Why is pain control important? Why is it so important for us? Why are we, taking this so importantly? So physical pain is the most common feared and debilitating experience patient and palliative care have. They're literally going through so much of pain and they really are afraid. They lack their self. They just try to humiliate their self. This is very important in understanding why this patient is they are in fear. You might see if you corner a dog, he might immediately lower his, tail and then he'll start growling at you. It's not because he's going to attack you. It's as his defensive position. It is a defense which he makes. And a patient who is in pain will also show defensive natures. Can anybody say what that defensive nature might be? A person who is in pain. He might have a defensive nature to you. Can anybody say what kind of a defensive thing he might show? Anyone? Yes, Hema. Hema was the first one who said the answer. Anger. A patient who is coming to you with lot of anger. He is talking, like everything is related to an anger tone, anger behavior. Everything is related to his angry man. He might be in pain. That is the one thing you need to press up here. Just because he came and shouted at you, just because he came and said some unethical or unparliamentary word to you, doesn't mean that this patient is okay. He might be in a lot of pain. So understanding that pain is very, very important when you come into palliative. So that is very important. So do understand that. I can see my co-host people are looking at their phones. I think I'm taking a lot of time. I'll go further. So pain is a very constant reminder of an illness also. So some person is having pain, and that is a reminder that the patient is having some illness which is having under it. And chances in the pain indicate a progression of illness or a change of mechanism of a pain towards chronicity. And the changes in pain, which actually may indicate the progression. It might indicate some progression, whether it is going into a chronic pain. That so-called indications have to be catched up then and there. The patient might be coming you with an acute pain over a period of time and you're not doing anything, and then it shoots up to be a chronic pain, and now we can't do anything after it has reached a particular spot. So this is very important that you need to know that progression has to be caught then and there, and it has to be independent. There is the time when palliative care comes in. That is a time when we come in and we give them hope and we give them a pain thing. Yes, yes. Jyoti Radhoda said not responsive to your questions, avoiding them. Yes, Vijayanti has said restless. Yes, everything. You can see multitude of attitudes from patients. They can show anything. Don't expect them to come and sit in front of you and say that, doctor, I have pain here. Can you treat it? Don't expect this. You can expect multitude of behaviors from them. Yes, repeated questions. It might irritate you. Yes, Priyanka, you're right. The patient might come and say repeated questions again and again and again, and even after answering so much of time. Yes, we are human beings too. Doctors and nurses are also human beings. We might have so much of other problems that we have to go focus. But still, remember one thing, if they are doing this, there is an underlying pathology. It is a pathology. Pain is a pathology. Understand that. Okay? Then pain prevents people from attending to other issues and developing the most important meaning of their life. Jesus avoided. If you are so much in pain, you just think about the periods itself. You have menstruation, and immediately you say that, oh, I'm not coming to the party. I'm not going there. I'm not attending it. Why? Yes, yes, Josna. Yes, that is very right. Chronic pain can make a person very depressed. I have seen a lot of people who are on antidepressants just because they have a lot of pain. They can't sleep. They don't even talk to their spouses. They don't even talk to their children. They isolate themselves. They seclude themselves. So this is something, pain is something which has to be taken up very seriously by everyone. It is not like that somebody's in pain, you give them paracetamol and ask them to shut down. It's not like that. Pain has a very deep meaning and it needs to be understood. Yes, Reena, people might get irritated. A lot of irritation can also happen. Yes. Okay, so we'll be talking in detail about the terms that we have seen and the type of pain that we have actually set. So the first pain that we usually see, if a person is having pain, it might be under two broad categories. That one is that is a nociceptive pain. Nociceptive, I told you, a nerve ending is there, which is taking up the stimulus and is taking up to the brain and telling that, Arey Baba, see, this is not good for you, you have to take it out. So that is nociceptive pain. And in nociceptive pain, the first thing that we'll be going through is a somatic pain. So we have learned in different sessions that what is somatic, what is visceral. We know we have a pleura, which is having a somatic and a visceral layer. Then we have in the peritoneum, which is again having a somatic and a visceral layer. So somatic is something outside, visceral is something inside. So this is something you need to understand and focus on. So when you talk about the somatic thing, we are talking about things which is jo bahar hai, which is outside, right? And those are stimulation to the peripheral receptors, outside receptors, which might include your skin, your muscles, your bone, your connective tissues, and all these organs which can have an expedition of this can show somatic nature of pain. This is very important. So you can understand that the pinprick which we are talking about was actually a somatic pain, okay, which comes under the nociceptive pain. And this clearly localized. You can tell where the pain is. The person who is having a rheumatic arthritis or a person who might having just a needle prick will come to you like this, I have pain here. He will localize it. It is here. It is the pain is here, right? So it is completely localized. The patient can literally say, ye kaha hai, kaisa hai, sab kuch. And the thing is that the type of pain literally is usually an aching or a gnawing type of pain, which is actually a pretty irritated way where the nauseous stimuli itself causes different types of pain. Okay, Maria has something, she has something to ask. What have you to say when we are given NS to patients with psychological pain and the pain is relieved post-NS? Yes, I will come to it. Because that one thing is actually called as a placebo effect. As doctors, we use it as a placebo effect where, see, somebody comes in and he's in pain, he's literally in pain, and then you help him out by doing something. That words may not help him. Like, okay, Dada, it's okay, don't worry, it's okay, you don't have pain. That's not the way. It is because of this particular pain, which actually what Maria actually asked is the pain of the mind. It is not a physical pain. It might be a mental pain. Okay. So that mental pain is being taken out when somebody cares. That particular person might be taken into an injection room. He might be made to sit. Somebody is caressing his hand. He's put in an IV cannula, and then somebody is giving him drip. somebody's observing him. So all these things together make him feel, okay, someone cares for me. And that thing, mind you, that thing as a placebo effect will work because it has been neuroscience has proved it that there's a one thing which happens in your brain is that your brain will emit so much of good hormones like dopamine. It will, yes, is it allowed? Yes, it is. In palliative medicine, anything is allowed if you can make the patient happy. If you can make the patient happy, anything is allowed. You just don't need to kill the patient, that's it. Unless and that, you can do anything to make the patient really happy. Okay, so dopamine surge is there and the patient might feel good. And at the end of time, this is one thing that can happen to help the patient. So moving on, there's response to simple analgesics, that is reasonable sensitive analgesics. That is the usual thing that we usually give as paracetamol and everything. Tramadol can be also used. So this is pretty response to all the simple analgesics that we use. So the next thing will be, as I've talked about somatic, I'll be talking about visceral also. So as it is written, like visceral, it is an infiltration and compression and the distension of the every thoracoabdominal organs that we have. The organs that we have are the one thing which is showing us a visceral in nature. So in actually, when we are talking about somatic, we told that this clearly localized. The person can literally say where the pain is actually. But when we come into visceral, it is a vague location. You don't know where it is. It is completely painful. You have a gastritis. Some people may come and say upper part completely, I have some problem. I have a problem in the complete upper part area. So this is actually something which is actually making a difference, saying that this complete thing is being not personalized and location is not a tactile area. It is like in a complete vague location. So it is disseminated. A person who is having an abdominal pain will not come and say that I have a pain which is in the lower right quadrant, 2 centimeters from the abdomen, from the umbilicus, and I have a pain right here. He won't say that. He will only say that I have a pain in my abdomen in this site. I can't localize it. And that particular thing directly brings this whole thing into a vague location, which is the visceral pain. So visceral pain is something which can be done. And just what type? How do you understand that the patient is in visceral? Again, the quality of pain. He has a deep squeezing pressure, like discomfort. Think about the Pirids pain that you have. I can only relate that pain because everybody has gone through that kind of a pain, right? Most of you that are sitting here. It is like a deep, as a squeezing pain, which is very discomfortable, and then it is like a pressuring thing. So it is happening somewhere down there because the uterus is down somewhere there. So it is whole of your lower abdominal pain will happen. It is not like 2.5 centimeters down the umbilicus, it is lateral or this to this. We can't say that, it is completely non, right? So that is one thing we need to understand about visceral pain. And mind you, one thing, visceral pain, it may involve to referred pain symptoms also. You might have referred pains. When you have a generalized pain, you might have referred pains to somewhere here or there. So that is the one reason why MI pain also refers to your left hand, because heart is a visceral organ. And when visceral organs are being, in pain, in heart attack also, you might be seeing that the patient is clenching his whole left, chest rather than pinpointing to one area, right? So this is very important. The type of pain that you go is very, very important. So it may involve the referred pain symptoms, and also it is associated with nausea and vomiting. And the very best thing about, visceral pain is it is very opioid responsive. Some like the patient that I have, earlier told that who was having cholangiocarcinoma, if he is being given opioid like a morphine, he'll be very, very responsive. The patient might have a really life turning over things in his life, that he might feel really good after taking morphine. So that is about visceral pain. Now coming to neuropathic pain, it is a constant pain. Neuropathic pain is a very constant pain, and somebody who might be working in kitchen on the clock and who is like after 40, 45 will have all the neuropathic pain in their hand because of the constant, flexion and the extension. We call it the carpal tunnel syndrome. And a patient who is having that kind of a diagnosis will understand that that neurological pain will always be a constant pain with so-called other features related to it. And the other features, I'll just name as per names. That is, the patient might have dysesthesia. These are also terms related to pain. So dysesthesia is something which is having an abnormal sensations of pins and needles and tingling or burning sensations that we have. Some like people who have diabetes, you have usually seen that patients who are having diabetes, may come to you with dysesthesia, that is abnormal sensations. They will say that I have a feeling of, some mirchi or the red chili powder which is being applied to my hand, and it feels so burning in nature. So that is very important. That is very important, because burning nature pain doesn't come from a somatic pain or a visceral pain or something like that. It's a different type of pain that you feel or you understand over a period of time, which is only associated with neuropathic pain. So if it's coming like I'm shooting like pain, I have burning like pain, I have pins and needles stuck around my, my skin, all these are related to neuropathic pain. So this is very important in understanding. And again, I have talked about allodynia. And again, allodynia is also seen in neuropathic pain. I told you, because of a neuropathic plexus, the patient who is having a herpes zoster infection, post herpes zoster, the patient might not even feel like wearing his, people who are coming to the OPDs with after a post herpes attack might not even wear a dress because he might be having allodynia. So that's very important. Then again, the type of pain might even include lancinating and sharp shooting pain, flashing pain, electricity conduction like pain. So these kinds of unusual presentations, you just think about neuropathic pain. So this is the reason why I just included this slide, so that you have an understanding when you are hearing abnormal pains, you have to immediately think of neuropathic pain. Okay. So the best thing is usually follows a clear nerve distribution. You know that the nerves run only through a particular distributions, right? So if we say that this person has chickenpox and then later it becomes shingles, we know that only from one area only the shingles is going. So similarly, in neuropathic pain also, it always follows a nerve distribution. So that is very important. If that is affected, the trigeminal is affected, the patient will only say pain in that area where the trigeminal is actually providing its source. So we are ending to our basic understanding about pain. He's just a person that we have seen in our palliative care. And can anybody say what he is thinking right now? Can anybody say, like, he is in pain? We can literally see that he's emaciated. He has oxygen tubes around him, and then like he's completely, if he's escaping, he's completely sorrow. We can see that he's sad. Can you say what all the things is he going through right now? Can anybody say about it? And then you will understand the dimension of understanding what pain is. Helplessness. Yes, Josna, you are very right. He is feeling helpless. Then, come on, everybody. It's just the second last slide or something. Be active. Yes, about his disease. Yes, Priyanka, you're right. Like about his disease and his family members, his everything. And I think you have already seen this image, right? So you might be understanding that, thinking about his future hopes. Yes, he's wounded. Yes, he's worried about his family. Yes, he's anxious. Yes, tired from the disease and future. Yes, thinking why it happened to me. Yes, what will be next in the slide? Yes. So you understand that there are a lot of things which can go through his mind, which eventually may surpass his physical needs, his physical pain. Yes, Jyoti, you're right. What will happen after me? So it's very important things, right? So the basic things which he might be wondering right now is this one. Can I pay the bills? I have done lot of, yes, about the financial thing. Yes, even he can blame God. Oh my God, so much responses. Okay. So, so he's thinking about all the medical bills that he has gone through a lot. Now he is thinking like financially, how am I gonna pay all the bills that I have gone through till now? So he's literally in that kind of a doubt, right? So the next thing he'll be thinking, how will I provide for my family? I'm in such a situation where I can't do even lift a small thing from the ground. He's in oxygen mask, right? So which literally means that if he does something, he will run out of oxygen and he will be breathless by then. So how will I provide for my family? That's very important. These are the things you should consider when you're talking to a patient. And then again, I don't want to eat or talk. He's in depressive state. He's isolating himself from everybody. I don't want to talk about it. I don't want to eat. I don't want to drink anything. Just leave me alone. That is the one thing that they're going to say. Leave me alone. Then there is too much pain. There is too much of pain. Not just the physical. It's everything. Thinking about, his family, thinking about his friends, thinking about his emotions. Everything is giving him too much of pain. Then what? I am unable to sleep. Can you even think just after one night of taking one night duty, do you think you can go back to your home and dance with your most important people when they might be doing a bhangra or they might be doing a dance over there? After a night duty, do you think that you can go and dance with them? You will immediately isolate yourself and you will go and sleep, right? That is what I do. So that is one thing that you need to understand. So he's unable to sleep, which itself will cause him a lot of pain because he's been doing that for the past 70 years. And after 70 years, he can't sleep properly because of a pain. So this itself will cause him a lot of trouble. And then the final big bang question. What is it? Am I going to die now? Please look at the slide for like 30 seconds and just think for yourself, how will you feel if you are standing in that person's image? I'll give you 30 seconds. So I hope you understand the pain. I hope you understand something. I think there is something going through your mind right now. Anybody wants to share? I'll just give the time. You just type in. I need to, end with this presentation and we'll need to go to the next thing. If anybody wants to say something, just type in. I'm going to read it out. What you felt after, watching this particular thing, after understanding what pain is. Okay? Start typing. So the main thing that we will learn in future aspects, we'll be learning of so much of physical, psychological, socio-economic, spiritual. All these things were directly related to the last picture that I was showing you. That is one thing that is, having so much of, problems that the patient might feel. So physical, yes, physical pain might be there. Psychological, yes, he might be going through wonders of thoughts that gives him pain. And socio-economic issues, again, he was thinking about his money to be paid to the bills. And spiritual, doesn't God love me anymore? Out of all these people, only I am being chosen. Why? Some people are even asked me, doctor, I didn't drink, I didn't smoke, I didn't do anything, and still I have lung cancer. Why? Does anybody have an answer for that? No one. No one in the world has an answer for that. I didn't do anything. I was a perfect man. And why did this happen to me? That is a very thing. And that actually disturbs the spiritual thing. Very important. So don't think that physical thing is the only one thing which can cause you pain. The whole concept of this is total pain, which includes physical, psychological, socio-economic, and spiritual. And mind you, again, illness-related pain is much more than just physical distress. The one person who is coming to you and saying that I am in pain, don't just start thinking about the physical disturbance or the physical things that he is going through. I think I will be boring you in the next session also. I think I will end it here. Okay? Any questions? I can see a lot of smiles. How was the session? Everybody's numb.
Thank you, Dr. Aravind, for the excellent session. Any doubts you have, please ask him. Otherwise, we can move on to the patient story. Thank you for the comments. Good, informative, and interactive. Very good. Thank you. Priyanka?
Good afternoon, sir.
Yeah, no.
Hello.
Yeah.
Good afternoon, ma'am. Good afternoon, everyone. Today I got a case presentation. Topic is, and the patient, now my patient's name is Nargis Parveen, age 30 years, gender female, and diagnosis CA breast in right. Presenting complaint. Patient in suffering pain in head and chest side, and quality of pain in chest side is mild, and pain score is 2 to 3. Headache present, constipation, nausea, insomnia, anorexia, and weight loss weakness is present. Now, history of illness. 3 years ago, patient feels some pain and noticed some lump in her right breast. It was gradually increased in size and hard in consistency. Then patient visits surgical department and got surgery, that is lumpectomy, and biopsy invasive breast cancer, no specific type. Then modified radical mastectomy is done 7th February 2022. Insomnia and anemia also present in the patient. And examination. Patient is alert, conscious, and oriented with the time, place, and person. And body weight, if patient's body weight is 40 kg, vital signs temperature 98.2 degree Fahrenheit, pulse is 70 beats per minute, respiration is 6 beats per minute, and blood pressure is 110 by 70 mm of Hg. Treatment and significant investigation. Routine investigation, hemoglobin level is 8.4 gram. There is patient suffering anemia, and others report is normal, and patients 28 radiation is done, and histopathological examination in breast carcinoma, invasive breast carcinoma, no specific type, and PET CT. So metabolically active residual metastatic lesion in liver, an active metastatic lesion in brain, frontal region, and blood transfusion also be given as per anemia, patient suffering anemia. And psychosocial aspect. 30 years old married woman living with her husband, that is 35 years old, and her two sons in her own house. She is a housewife, and her husband is working daily labor, and monthly income is 4,000 per month. And he is taking care of her wife, and she is patient, and now main source is income for her husband, and she communicate with us through the cell phone, and she is a very strong woman and does not fear about his disease, but she worry about her family and financial condition also. Medicine is given as per doctor advice: tablet paracetamol, iron, folic acid, calcium, and vitamin D3, and pan-40. Main concern: pain in right chest side with weakness present, anemia, and financial problem is also be happen. Summary. My patient's name is Nargis Parvin, 30 years old, diagnosed CA breast and right, modified radical mastectomy is done on 17 February 2022. Now she is treated at Arjikar Hospital in Kolkata and palliative OPD. Her chief complaint is headache, right side chest wall pain, constipation, anemia, and medicine is given for the pain management. And discussion point is: do you need to prove palliative care for this patient? What are the problems faced by this patient? What all can be done for this patient and her family?
Okay, thank you, Priyan, for the wonderful patient presentation. So, anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. Anybody need any clarification? No. So I think this presentation is clear to everyone. Now we heard about the introduction to pain and also palliative care. Now Priyanka had come with her patient story. So we are the person to contribute your suggestions for improving quality of life of this patient and family. So please, we would like to hear from you all. Okay. So Jyoti said palliative care has to be done and counseling is must for the patient. Okay. And family also. Any other points? So you have to put yourself into that patient's side and think. So what are the problems faced by this patient? Others, please respond. And go back to the main concerns. Yeah. So this is the main concern of the patient. So for pain, I'm glad you have mentioned about the pain score. But the next time onwards, you have to, if the patient is having pain, you have to mention about the PQRST.
Okay, ma'am.
Okay. It's for others. So how will you manage pain for this patient? This patient's pain score is 3 to 4, I think. Right,
2
Priyanka?
to 3.
2 to 3.
Ma'am, 2 to. Huh.
2 to 3. Okay. What medication is going on for pain?
Ma'am, paracetamol is going on for pain.
Is she getting adequate pain relief with paracetamol?
Ma'am, paracetamol 1 gram.
Sorry. Could you please repeat?
Paracetamol 1 gram.
Okay, okay. So my question is that patient is getting adequate pain relief with paracetamol?
Yes, ma'am.
Yes. Okay, that's good.
Ma'am, can you answer discussion question? Can I answer, ma'am?
Yeah.
Okay, ma'am. Ma'am, first question, do you need to provide palliative care for this patient? Yes, in palliative care, not only we treated her presenting complaint and disease, but also we treated her mental illness and answer all query about his disease to the patient and his family members.
Okay.
Okay, ma'am. Second question is, what are the problems faced by this patient? This patient problems, psychological issues, some pain, constipation, nausea, insomnia, anorexia, etc., and feelings of burden to her caregiver, and financial issue, and social isolation, loss and depression also. And what all can be done for these patients and her family? For patients, pain level should be pain level should be assessed, and diversional therapy should be given, and analgesic group of drugs should be given as per doctor advice, and iron-rich food should be provided, such as the egg, green leafy vegetable, as his financial as per financial condition, and mental support should be given, and proper explanation should be given about the disease condition.
Okay. Thank you, Priyanka. Thank you.
ma'am.
Okay. So you did well. Anyway, so we need to discuss about this patient. You have mentioned about her main problems: pain, headache, constipation, nausea, insomnia, anorexia, weight loss, weakness. So we would like to hear from you about her other physical problems, constipation. How do you manage? now is there any problem? Still constipation is there. That all things we would like to hear from you.
Yes, ma'am. As per constipation, we told enough water should be intake, and for relief constipation, insomnia should prevent
Okay. So now the patient is getting adequate sleep and pain relief, right?
Yes, ma'am.
Okay. So what about her children? She has 2 sons now.
She has 2 sons, huh? Yes.
Yeah. So
She is
Did you-
worried about
did-
her family and also children. And
okay. Did you able to meet her children?
no,
No.
no.
Okay. So who is the primary caregiver?
He's her husband.
Her husband. Okay. So when will you give palliative care for this
We need
patient?
her husband.
Sorry, her husband and anybody else?
Only husband.
Only husband. Okay. So from the beginning itself, we learned about palliative care is for patient and the family too. Here we have to think about the patient family also, and also we have to think about her sons, because they are all focusing on her treatment. The childrens will not get that proper attention, and also the childrens, usually the childrens not they doesn't know what is happening to their mother. So that is also important. You have to talk to them also. So sometimes the maybe husband or mother will be requesting you to not tell our children, because that is also important. They should know. They are there. So we have to convince the patient and the family about the importance of knowing the children about her mother's problem. So that is also important. Do you want to add anything? Here we have to think about physical problem, psychosocial issues, spiritual issues, and emotional problems. So she is having cancer breast. She is not able to fulfill her wish, because she is a mother, she is a wife. Because of her disease, she is not able to meet all those things. So that will be affecting the patient emotionally, socially, and spiritually. Because of my disease, God punished me like this. Why happened to me? These kind of questions will be there all the times. So I have a small request to you to all is, we are the persons to spend more time with the patient. Okay, so if you get time, anytime, so go there and listen their problems. We will give some physical, we will try to manage their physical problems. We all focusing on physical problems. But at the same time, you have to understand that if they have a psychosocial issues there, their physical distress will increase. We have to look into the other aspects too. Then only we can able to improve the quality of life. So if you are not giving proper attention to the other aspects, we will not be able to control their pain fully. So if you want to give a good palliative care to the patient, you have to give that attention to the 4 aspects: physical, emotional, social, and spiritual. So that concept Dr. Aravind explained very well. the importance of concepts, the importance of assessment, importance of addressing those issues. So if you do the proper assessment, definitely you will give good treatment to the patient. So that is very, very important. If you see a pain patients, you have to assess well, have to look into the 4 aspects. Any questions? So we will discuss the management part next session. So any questions there, we will try to answer. Otherwise, we can wind up. Anything you want to add? No.
Anything regarding the presentation or anything regarding the general case which you have a query?
So Hema is mentioned about weak opioids. That will be taken by the next session, because today the introduction to the pain only. What is pain? What is the pathophysiology of pain? The concepts, that all things. How to assess pain? That all things. Management part we will discuss next week.
Priyanka, it was a good presentation.
Okay. Okay.
Thank you, sir.
Okay. Thank you.